Well, good afternoon to everyone, and thank you very much for joining this webinar this afternoon. My name is Dr. Leanne Ramsumar Hariprasad, and I am a public health researcher and a research uptake specialist at the South African Medical Research Council. It really gives me great pleasure to share this very important webinar this afternoon, and I want to start by thanking all of you for making yourselves available for this webinar. I think this afternoon the webinar comes at a very important and what I believe timely moment on promoting health in a pandemic, and specifically looking at what we can learn from the COVID-19 pandemic, which is a reality for us all. Health promotion has really been on the national agenda for a long time, and the COVID-19 pandemic has thrown into sharp focus the need to adopt health promotion approaches to address the health behaviors that are related to reducing the transmission of COVID-19, and also generally for advocating better health. So this afternoon we have with us a number of esteemed speakers on the panel who've both been working in the field of health promotion, advancing the national agenda on it, and also advocating for its centrality in pursuing health in South Africa. This webinar also comes at a time when some of us have woken up this morning to the sad news of the passing of an early champion for health promotion and for its formalization in South Africa and in the higher education sector. And that was Mr. Anil Bhagwanji. Anil passed away last night from COVID-related illness. And today we want to remember his early efforts. He was a strong advocate for health promotion and tobacco control. And his career really spanned the spectrum of health promotion from the grassroots level all the way up to the strategic policy level. So he leaves behind a very strong legacy, and we want to take a moment just to remember him and his efforts and send comfort and condolences to the family. This afternoon we have 5 speakers who will be taking us through the various topics. And the first one is someone who I have known quite well over the last 2 years and who has been passionately advocating for health promotion in the last, well, ever since I met her, and that is Ms. Jane Simmons. Jane is a public health specialist who's working at the South African Medical Research Council in the field of health promotion and behavior change communication. She actually started her professional career as a teacher and then went on to do a master's in public health in social and behavior change communication at WITS. She has been using her background in SBCC to work with parents and adolescents in understanding and supporting the changes in adolescent sexual behavior, specifically to reduce HIV infection and unplanned pregnancies. And Jane has really been playing a very active role in health promotion through the development of the Health Promotion Development Foundation, and as well as a project in Alexandra. And she's been working with PASA as part of the special interest group, who are our hosts today, to really advocate for health promotion approaches in South Africa. Jane recently founded an NGO called Go, 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 Go. And the aim of this NGO is to recognize and support the grandmothers, or what we fondly know as Gogos, in their role for raising children and empowering the third generation caregivers as agents for health promotion in their families and using behavior change communication approaches. Jane is also a member of the SBCC advisory group and has presented on health promotion and behavior change more recently, and also quite actively, to a number of groups, including the Behavior Change Communication Ministerial Advisory Committee and the National Coronavirus Command Council. So we're very, very privileged to have Jane with us today. And Jane, over to you.
Thank you, Leanne, and thank you. And welcome to everybody, and thank you for joining us. Let me just share my screen.
Yes, that's perfect.
So I'm aware that a number of people here are health promotion advocates and have histories in health promotion, and Yes, Leanne has known me for a long time. She was my lecturer in my Master's in Social Behavior Change Communication. So I'm just going to run through a brief background to health promotion, just so that we know where we all are. I don't want to assume that there's a knowledge. So if you do know what I'm referring to, please bear with me. But, just to put everybody into what we are understanding health promotion to be and our conversations on it. So health promotion simply is keeping people healthy. And when I speak about health promotion, I tell people the importance of health promotion is that effectively it costs less to keep people healthy than to treat sick people. In health promotion, we need to address the determinants of health, and we need to shift behavioral norms from waiting to get sick and seeking treatment and cure and management to keeping healthy, to avoid needing treatment. And I think this is where COVID has given us an opportunity to reinvigorate and re-advocate for health promotion, because government and countries around the world are spending billions in shifting the behavioral norm from people waiting to get COVID to keeping people healthy and to avoid getting COVID. Social behavior, health promotion needs social change, which includes behavior change. And another thing that makes health promotion very important going forward is that with the implementation of the National Health Insurance Fund, that fund will not survive by treating millions and millions of sick people. That fund, in fact, needs less sick people to treat in order to not be overwhelmed, and we need a healthier country. So there are three vital reasons to promote good health. People desire healthy lives. They don't want physical, mental, and social problems. They want to be well. Good population health is essential for economic and social development, and unhealthy people place an unnecessary burden on health services. So health promotion has been discussed for a while. There's the Untitled Chapter, where you look at 3 basic strategies for health promotion to enable, to mediate and advocate for change. You build healthy circles, building healthy public policies, which is the circle around this diagram, holding this all together. And then the wings inside the diagram address all 5 areas that need to be managed in health promotion, which in an integrated and complementary manner. We need to reorientate health services, create supportive environments, develop personal skills, and strengthen community action. The Shanghai Declaration on Promoting Health again looked at ways of promoting health for the 2030 Agenda for Sustainable Development. And this declaration recognized the importance of integrated and cross-sectoral planning, and that health can't just be top-down, and it needs to go from bottom up as well. It needs a range of sectors that impact on health and collaborations through and across these sectors to enable healthy outcomes. Country initiatives need to be important in terms of regulatory mechanisms or policies. So ensuring that healthy food is available. It's not helpful telling people to eat healthy food if it's not available. And there needs to be city and urban conglomeration across different sectors. The WHO definition of health promotion is the process of enabling people to increase control over and to improve their health. It moves beyond a focus on individual behavior towards a wide range of social, environmental interventions. And the reason why I think it's important to hold on that it's more than individual behavior is if we look at the call by the Minister of Health and the President of South Africa about the importance of shifting our behavior to address COVID and reduce the risk of COVID. There's a lot of pressure being put on individual behavior. Wash your hands, wear a mask, and physically distance. And I think we need to look further than that to this range of social and environmental interventions that is needed. So, as I was saying, keeping people healthy can be complicated. People often have to be responsible for their own health in the face of economic and social realities, which they do not have the means to address or change. Health promotion experts, of which there are a number on this webinar, have indicated there is huge potential for health promotion to impact on population health, and health promoters have been calling for increased funding and support for health promotion and an independent health promotion and development foundation in South Africa for over 15 years. And Sue Goldstein is going to be speaking to us about this. We cannot afford, from a human capital and health affordability perspective, to not keep people healthy. And again, COVID is showing us that the impact of COVID on people with comorbidities of hypertension, diabetes, is already showing us severe negative consequences. So not only are we dealing with our comorbidities that are increasing in terms of non-communicable diseases, but COVID is highlighting those and making the impact worse for those people. So what are the key requirements for good health? It's dependent on social, political, and economic forces, not just individuals. Unemployment, education, housing, nutrition, water, sanitation, and other social determinants are critically important to health. But often those areas are not part of the Department of Health and do not, are not constitute part of health services and health systems. So we need to look at what can we do to combat the direct behavioral determinants of ill health in terms of key direct and modifiable risk factors. South Africa needs to look closely at NCDs. The main behavioral determinants of these areas are tobacco use, unhealthy diet, abuse of alcohol, physical inactivity, and air pollution. We've seen tobacco use and alcohol use very much in the press and in the focus of the media and research at the moment with COVID. Reducing these risk factors can significantly reduce morbidity and mortality. And what's very important too, moving towards key health, and again, this has been pulled up by the Minister of Health and the Minister of Social Development by the establishment of the Behavior Change Communication MAC, is how do we change behavior so that it is sustainable and maintainable for an individual within a social environment, which is why we want to have social and behavior change communication as central to this program. So briefly, to look at NCD's mortality, the probability of dying prematurely between the ages of 30 and 70 in South Africa due to NCDs, including cardiovascular disease, cancer, diabetes, and chronic respiratory diseases, is 34% for males and 24% for females. That's really high. Not only is that a high cost in mortality, but it's a high cost in economic cost. In terms of its Sustainable Development Goals, we have a target to reduce this by 1/3 by 2030. How are we going to do this? NCDs are having a significant impact on the health of South Africa and the healthcare system. There's accumulated losses in GDP between 2006 and 2015 from NCDs of 26 billion rand. The economic cost of productivity loss to ill health in South Africa, largely from NCDs, was a total of 6.7% of GDP in 2015, as it's expected to increase to 7% by 2030. Moderate obesity is associated with an 11% increase in healthcare costs, and severe obesity with a 23% in healthcare costs. And we look at research from the WHO. If you invest in interventions of NCDs, by 2030, there will be a return of $7 for every dollar spent per person. Briefly, if one looks at hypertension, the increases in South Africa, over 80% of women in 2016 had hypertension over 65 years. But look how high this is in women of 54 and 45 to 54 and 55 to 64. Again, in men, this is increasing right through all the age groups over the years. In diabetes, we look at diabetes, and if this graph, I can just point out to you, the male axis, vertical axis, is up to 60%. The female one goes up to 80. So we're looking at over 80% of women in the 55 to 64 age group and the 45 to 54 age group were obese in 2016. So Professor Charles Perry from the SAMRC and Professor Melvin Freeman and I did some research and prepared a technical report for the Medical Research Council on health promotion and NCDs, where we are in South Africa and where we need to be. And part of that was interviewing a number of health experts. So these are what they were saying. The experts were saying health promotion is underperforming. The funding for health promotion is laughable. The problem with health promotion activities is that the vision is not, the outcome is not immediate, and government wants to see outcomes in a short space of time. There's relatively little money available for health promotion, and it's often used on education campaigns and not on actual change. It's important to start health promotion right from the beginning of the life course. Could play an important role in combating nutrition issues. It's important to look at poverty, gender issues. The health promotion workforce in South Africa looks most at health education and health promotion in a rather narrow framework of just seeing information and education campaigns. And we need to understand why ill health trends are occurring and identify the root of the problem and intervene appropriately. So we can't, again, just ask people to make decisions to their diet or exercise, which are very difficult for them to do in their circumstances. But there needs to be a bigger initiative about this. So there are limits on health promotion currently. The intersectoral nature of health is often not recognized or adequately acknowledged. Also, government is caught in a double bind, whether do they treat people who are sick or do they prevent illness in people who are healthy? Now, of course, government has to treat people who are sick and cure and manage people who are ill. That money cannot be taken to health promotion, but there needs to be money in addition to treatment, to prevention. The knowledge base for health promotion in South Africa is poor. What works in South Africa? What can be globally extrapolated? What can we use? What innovations can be used in South Africa that would be unique in South Africa? What are our best buys? And which demonstration projects need to be run that are evaluated to see what works and why? It's important to look at the NCD risk factors if we're talking about health promotion. So looking at WHO information in the region of the Americas, 80% of all heart disease, stroke, and type 2 diabetes, and 40% of cancer is preventable through multi-sectoral action. And given that many of the countries in the PAHO share socioeconomic similarities with South Africa, analogous figures are probable in South Africa too. So there's an overwhelming and broad consensus building from the United Nations General Assembly and other organizations that we need to comprehensively address NCD mortality and morbidity through a health and inequalities, a whole of government and a whole of society approach. But changing risk factors and reducing them is not always easy. Health behaviors and choices are practiced by individuals which are often driven by forces that lie outside their direct control, which is why we need to look at social change, leading to a change in health behaviors that involve a complex set of interventions that go beyond the individual and involve cultural, social, and economic factors, including the social determinants of health. We need to tackle both proximal and distal causes of health. We need to address the social determinants of health, and these is where the intersectoral activity and mobilizing and advocacy needs to come in. We need to address poor housing, inadequate water and sanitation, a suboptimal food environment, high levels of alcohol and substance abuse, low levels of social cohesion, and inadequate health system responses. Importantly, we can look at the role of fiscal and financial interventions. We've introduced this sugar-sweetened beverages tax. That's going to be avert an estimated 8,000 premature deaths. We can look at the role of increased taxes on cigarettes, and I see we've got Yusuf Salute on this call. We've got excise duties, subsidies, and income transfers. So we can work on these to reduce costs and then raise 6 billion in tax revenues per annum. So we need to look at what do we need here immediately. It needs social change, and this can be complicated and hard. We need more than information, education, and campaigns and individual knowledge. We need motivation, self-efficacy, and an enabling environment. We need behavior change communication, social mobilization, and advocacy. And I'm glad to have Noe and Lydia on the call to talk to us about this. And importantly, we need different government departments and stakeholders to work together. And government has started with this process by bringing together the Department of Health and the Department of Social Development to create the Behavior Change Communication Ministerial Advisory Committee, to acknowledge that this is something that needs to be done across departments. But most importantly, our South Africa's specific realities and needs, including poverty and its related behavioral impacts and health consequences, must be taken into account. So how do we change people's behavior and choices? We can't just tell an individual how to be healthy. You can't just say, eat better, exercise more, wash your hands, wear a mask. People need support and social structures to promote, sustain, and maintain healthy choices. Some of these changes are quite indirect. So you might have to improve safety on streets with more policing to enable exercise. You might have to facilitate soccer fields that are maintained to create exercise. Healthy food needs to be subsidized and more easily available. And things like putting in place legislation that prohibits the sale of alcohol and tobacco from within a certain area at schools needs to be put in place. So to talk about this thing that we call social behavior change communication, which we presented to the NCCC, to the Ministerial Advisory Committee on Behavior Change Communication, and a number of other possible partners. So I think you can all see my mouse, but this model uses something called the socio-ecological model for change. And if you see, you have 4 layers of capacity that need to be mobilized and active for a change to happen. And if we keep in mind that we do not want a change to be a once-off, it needs to be sustainable and a maintained change. It's not enough to use a mask once, or to use a mask when you only go out, or to only use a mask at work. We need to look at how do we shift a behavior so that it is possible to sustain it. So you can have your individual information. I need to wear a mask. You know that. You then need to negotiate or work on the relationship with your family and friends and partners, but they all wear masks. Your parents need to remind you when you leave home, take your mask. Your children need to say to you, take your mask. Your friends need to say to you, I don't want to hang out with you unless we're all wearing masks. So you then all negotiate that you're going to wear masks. You then reach the community level. And in this level is things like, what's happening to your access to masks? Is a mask there as a product? Okay, what is happening in community? If you go to a supermarket or a shopping center, are people wearing masks, or are they not wearing masks? Are you the odd one out with a mask, or are you the odd one out without a mask? And this is where we look for this change in a norm, where mask wearing becomes a norm. And then here we have our enabling environment, where we have a policy, or as the president said, it is now mandatory to wear masks, and examples set by leaders, governments, NGOs, and private sector. But very importantly, all of these levels have to be active, because if any of them are missing, that behavior change cannot take place. And I just want to bring your attention to the cross-cutting factors, that information, knowledge, motivation, attitudes, belief, the ability to act, and your perceived norms are critical to changing your behavior. And those are impacted by things like structural, environmental, economic, fiscal, and gender-based issues. COVID is demonstrating the importance of health promotion. Again, to say that the prevailing concern is about, in the face of COVID, is keeping healthy and not getting it. But we need to make sure that our focus is not just on the prevention of COVID, but on promoting long-term health. Addressing COVID means addressing issues of sanitation, spatial distancing in low-income areas. Again, it needs to look at a change of behavior like hand washing, face masks, physical distancing are all forms of human change of behavior, but it needs to be more than that. We need to look at individual behavior change downstream, at midstream level changes through interventions affecting organizations and communities, working with religious organizations, workplaces, and shopping malls, and upstream levels through informing policies affecting population. For example, SASSA made grant days for older people, mandatory mask wearing, provision of water from water and sanitation. Just for people who would like to refer to further information about this, is the technical report that the MRC did. And then there have been 2 articles in the South African Medical Journal on health promotion. There's also been a submission to the Parliamentary Portfolio Committee on Health for the National Insurance Bill. Yeah, those are the articles. So thank you, everybody. That's the end of me, and we look forward to the next presentation.
Thanks very much, Jane, for that very comprehensive overview of health promotion. I think you did a really good job of both providing motivation for why we need to be focusing on health promotion, what progress we've made, but also the major tasks that lie ahead for us as a country, advocating for and using health promotion approaches. We're going to move on to the next speaker, and I want to just remind people that we have a Q&A facility which enables you to ask your questions. Please do type your questions down in the Q&A chat box, and we will have a session at the end where we will respond to the different presentations. But for now, we're going to move on to our colleague from the Department of Health, and that is Ms. Simi Lynn Mueng Mahlangu, and she's the Chief Director of Health Promotion, Nutrition and Oral Health and Food Control at the National Department of Health. Lynn was previously a Director of Nutrition, and in her previous life, she calls it, was a lecturer at the Medical University of South Africa, which is Medunsa. Her basic and master's degrees are in the field of nutrition, and she has a postgraduate diploma in health management and currently pursuing her PhD in the area of childhood obesity. Lynn has really been instrumental in the development and implementation of key legislation in South Africa around health promotion and the adoption of the Tshwane Declaration, which led to policy change on infant and young child feeding in South Africa as one of her achievements. And this was followed by the development of the strategy for the prevention and control of obesity in South Africa. So Lynn, we welcome you. Thank you very much for joining us and giving us your time during what must be a very, very busy time for you. And over to you.
Can you please share my slides? I did send them to Jane and requested her to share for me.
Sure. Jane, are you able to assist Lynn with sharing her slides, please? Jane?
I hope she's still connected.
She is. I know she's currently muted. Jane, are you able to please share Lynn's slides?
I'm just looking for them. Could just give me a moment.
Maybe I can just start while she's trying.
Yes, please do, Lynn.
Oh, go ahead, Jane. Go ahead, Lynn.
Thank you very much, Jane, for the comprehensive presentation, which laid a very good foundation, I think, for presentations that will be following after. I was just requested to share what lessons have I and maybe some of us learned during this period in relation to health promotion. When Jane asked me, I told her one lesson which I learned, which I think I will cover it as we talk. I can't share it now, otherwise it will be the end of my presentation. Are you succeeding, Jane?
Nearly there.
Okay, no, that's fine. I realize there are colleagues of mine who have joined us here.
There we go.
Okay, thank you. Thank you. I will move straight, we can move straight to the next slide. And just to remind us how soon we have reached the level of infections, because it was only on the 5th of March when we had 1 case. And now 4 months or 5 months down the line, we have more than 500,000 cases in South Africa, with a total of about 9,600 deaths. And we often talk about many of these could have been prevented, which is true if we had if people were adhering to the health promotion initiatives and messages that we are sharing. The next one. I have sort of developed this slide for health promoters who have your PhDs. Please don't try and put this as a model comparing with any other models. This is just what I put myself in terms of where we come from and what we have observed with changes over time, starting from where people were in denial, disbelieving, and some of them actually talking about this disease as being a disease of the rich people who travel abroad, and it's not us. So we have no reason to be scared. We will not be affected. And it also came in, I mean, as a new disease, which created a lot of confusions because we kept on updating messages that we were sending to people. It resulted in a lot of disruptions in households, in families, especially for those families where we normally work for one day. The lockdown has affected us in many ways. We work for one day, come home with 200 rands, buy your dinner for the day. So it did create a lot of challenges in such households. And there were a lot of frustrations. Somewhere people were talking about regulation fatigue. And this resulted in people disobeying and resulting in increased infections as well, and the cycle of fear again. Go to the next slide. Jane, the next slide, please. Jane, can you assist me?
Sorry, the next slide is not going. I'm trying.
Okay.
There we are.
All right. I mean, what we know, and I think what Jane just recently indicated, is that COVID is solely driven by behavior change, the infections. And yet we also know that the increase in life expectancy in South Africa was not mainly driven by behavior change. It was because we're giving a pill to treat disease. And our history also tells us that behavior change interventions have always been challenging. We have implemented a lot, but there's always been challenges. Now, we are saying for us to succeed, there are certain ingredients which we need, and political will is one of those. Consistent communication in various sectors and having the same policies as Jane indicated, the all of government approach, health in all policies. We need to have an enabling environment, human resources, financial resources, community involvement, and knowledge increased at all levels. Now, with COVID, we had all of these. But we still have people, a lot of people who have not changed behavior. Maybe even before touching to this, we have people who have enabling environments who have not changed. We have people who have the knowledge who have not changed. So what are the lessons that we can learn from this experience, and maybe in terms of trying to strengthen health promotion as we move forward? One is that behavior change is influenced by various individual circumstances, which may be more important to an individual than the pandemic itself. And this is very scary because we are seeing our family members falling and dying in front of us. But it shows that there are other factors within as individuals and in our families that are more important than what we are seeing. Also, emotional and social ills seem to supersede any physical pain that we may be feeling due to this. People are depressed. There are other social factors. which are affecting how we may or change our own behaviors. The hindrances to behavior change that we have always understood may need to be revisited, including lack of leadership. You also indicated some, Jane, when you are talking, not enough budget for health promotion, you know, all those issues, we may need to revisit them or maybe add others if we are not changing. Our messages need to be more detailed. We need to have the science that we get from researchers translated and even understood by the most illiterate person in the same way. Because most of the time we have been sending 3 messages: wear a mask, social distancing, wash hands. But I'm picking up as you are observing people's behaviors that we actually don't understand the whys behind it. Recently I saw, I just want to divert a little bit. I saw a family with who were in a supermarket with 2 children, 2-year-old twins, who were playing on the floors, falling, touching, doing this. And the way I was observing it, parents were not worried, were not concerned, because I don't think there is that understanding that you can actually even get it somewhere as you are touching. And in between, there was no sanitizing. So there is a challenge that possibly our messages are not translated adequately. The science behind the disease is not translated adequately. Or maybe because we are not hearing deaths of children below 5, it's possible that parents think children below 5 are okay. We may need to have a measure to determine what percentage of the targeted population would need to change behavior if we were to say health promotion was successful or our interventions were successful. Maybe this already exists, but I may not be aware. Next slide.
Sorry.
Okay. I would be struggling more where I'm sitting because I'm not technologically good. So at least when you are struggling, I know you will get it right.
My laptop is stuck. So carry on, Lynn, and I'll keep trying.
Okay, I just wanted also to highlight some of the issues of behavior, just touching a little bit on the challenge we're having throughout this period of people who are smokers, people who want alcohol to be, bars to be open. For me, it also gave us an indication that it means that the science, or not only the science, people are not interested in the risks, or the addiction is much more powerful than the risk itself. And maybe this is one of the most important messages that we may need to. The next slide is actually just talking about the many models that we have on behavior change. And I'm only raising a question here to say, do we have models that have been developed by the community in terms of how their behaviors may be influenced? Or some of the models were mainly developed maybe for a PhD study or something like the one which I developed on my own, which doesn't come from anywhere. So we may need to look at that as well to say, as we move forward in terms of developing future models, how do we engage communities to assist us in developing models that talk to them? Next slide. Luckily, I don't have many slides. The next slide. I'm just bringing this up here in terms of what our president is now saying, especially in terms of the affected. But maybe we are saying to ourselves, our major challenge is that we are currently all living in fear of this pandemic. And we are also experiencing a challenge where we are not sure how to support our bereaved families in a way that is outside the usual cultural practice. Is there a way that we can encourage people to support each other? How do we design relevant approaches where people may feel that, you know, I'm not alone? Because we are seeing people who are mourning alone in their homes because of the fear that we have. Is this a health promotion issue, or is it a policy issue? Is it an advocacy issue? Or does it need leadership at whatever level? What support can we provide? So basically, colleagues, as I indicated earlier, this is saying what lessons have we learned about COVID? What is it teaching us in terms of health promotion? There are a lot of lessons, but one of the key ones for me is that we had all the resources, we've mobilized, we have political will, we have so much money that has been put into managing COVID, but we are still struggling. And maybe the issue is, what is it that we need to do more? What can we do more? And that's it for me. I just wanted to highlight these issues, and thank you. You can all take care. We should stay safe. Thank you.
Thank you very much, Lynn, and also thanks to Jane for navigating those slides. Lynn, I think you raised some really important issues that we need to be reflecting on in this call, and perhaps people can reflect on it throughout the course of the webinar, and do post your chats or your question and answers. One of the issues that stuck out for me was the issue of research translation, and how, as a country, both with our partnerships with scientists and people who are working at the coalface of health promotion, we actually need to be paying much more attention to translating a lot of the evidence that we have about effective approaches to health promotion, so that it's understood by people at the grassroots level. And I think that's ultimately one of the fundamental principles of health promotion. So thank you very much for that, Lynn. We're now going to move on to our next speaker, and that is Ms. Noe Mdai. Noe was talking to us before the call, and she actually has a very strong activist background. She was born in Gugulethu, and she attended school there, where she first started to be involved in the struggle in 1975, fighting issues at the school level around Bantu education. And later in the 1980s, she began to be involved in civic organizations. And she says she was fighting bread and butter issues as a civic activist. And so her portfolio was health, and she began to become much more involved in the health struggle when people were queuing outside clinics at 3 a.m. And she started a partnership with UCT's Learning Network, where she was trained on the roles and responsibilities of health of health committees, and became a health committee member herself in the late 80s, largely representing the community of Gugulethu and monitoring those services. Noe does come from a family of activists, and many personal health issues that affected her family as well really did provide the motivation for the work that she's done. Noe is currently a provincial executive member of the South African National Civic Organization, a member of the steering committee of the People's Health Movement, and is furthering her studies doing transformation leadership at UWC, and is now doing adult education at UCT. So Noe, thank you very much for joining us this afternoon, and over to you.
Good afternoon, everyone. In this month of us as women taking leadership, let me first, I think now timing is really not good, but we must make it good. Facing the pandemic, the virus that made our community, everyone, to have a lot of fear. People are dying. When people are dying, lots of families has lose their family members. But in all that, we are not giving it up as a community. Studying about the behavior, you know, we first ignore this virus. Let me straight say, as an activist, because there were uh, lots of social medias was roaming around. That makes really people to behave in the wrong, bad manners. That yes, this thing comes from the white people who are traveling overseas and doing this and this. This comes with the Chinese. Why we must put mask on? They want really us to die, but it's good that the awareness organizations like PHM to the level of community, educating people about the virus. What is this virus all about? What we were doing even yesterday, myself and Lydia, we started at Kukuletu, trying to change the mindset of our people when going to malls, not wearing their mask, intervene in social distance when our people are at clinics, all over where lots of people are going. Even our senior citizens trying to keep them from not going to the clinic and fetch their medication, have meetings, have decisions that we took with facility managers that our senior citizens must get their medication at home. All those interventions that we did as community activists. I think in May, when we were looking at the numbers at Kukuletu, they were rising every day. That makes really a fear, and people were dying. It's where we started to think and said, the behavior is not going to help us. Let us come to the party and do whatever we can do to prevent and to make our people aware that this is real. The virus is amongst us. What are we going to do? Let us all come to the party. Let us take things serious. When we say, let us wash our hands, let us have our bleach in our homes, let us clean our handles, let us, the ignorance, even our children, they don't want to listen to us because the schools are closed and they want to go play outside. And then when they come in the house, educate street committees, call street committees to do their duty, that each and every household have to have a jig, and each and every household have to have education, distributing pamphlets. Really, the education has an impact because after that, we have seen that really slowly but sure numbers are reducing. And even the numbers of people that are dying has decreasing. I think what we are busy doing now with people's settlement, education, really to take out that stereotype mind of us thinking, putting a blame to the next person when something happened, you know. Yes, we know that things are not good. When we talk even of the unban of the alcohol, we said the alcohol must be banned as people that are going to the clinics every day, seeing that when the alcohol was giving a chance that everyone can drink. We had the problems in our clinic. People were stabbed, accidents and all that. But that needs us to educate our people. What is good about it is that people really are listening because people are dying. That's what we said now. It's good that the what we are doing, even educate our people on the healthy style of living, try to be involved in NCD programs, food gardening, the healthy lifestyle, and even, sorry, if you cannot do it, there are relevant stakeholders of service provider that will refer our people that we know that we cannot build Rome a day or overnight, but we are getting there, educate our people. We said each one teach one. That's all that I can say, that we must spread the gospel all over where we are. The attitude really is changing, because when I was standing at Clicks in our mall yesterday, day before yesterday, standing in a queue, the one was queuing after me. When I was moving to my line, she started moving to my arms. Then I said, hello, hey. Then she said, oh, I forget social distance. We are reminding ourselves, keep on reminding community. I think it is changing. Thank
Thank you very much for that, Noe. I think your presentation has really brought home for us the real issues that people are facing at the grassroots level. And it also raised for me the issue of making sure that in addition to education, we're also providing people with the necessary resources that they need in order to make sure that they are able to actually carry out those health promoting behaviors,
you.
particularly in the current COVID reality. I think the presence of people like Professor Charles Parry and others who have been also at the center of issues around the alcohol ban. It's really heartening for us to know that that these have been felt. The effects of the ban have been felt quite strongly across communities, and that actually our work is not in vain. Thank you so much for all the work that you continue to do at the grassroots level, and for your input here today. You can please continue to stay on as we move on to the next speaker. And the next speaker this afternoon is Professor Lydia Cairncross, sorry. And Lydia is going to be talking to us this afternoon about how COVID has affected the health services and the patient family community ecosystem, bridging the gap as a catalyst for health promotion. Lydia is an associate professor in the Department of Surgery at UCT and Critiskir, and she's also a member of the UCT's Global Surgery Steering Committee. Her input here today speaks to her background as a health activist, a community educator, and a member of the People's Health Movement of South Africa. During the COVID pandemic, Lydia has worked as a doctor in the COVID service in her hospital. She's advocated for justice and for equity in the COVID response through the COVID-19 People's Coalition, and has conducted COVID-19 workshops in communities in the Western Cape. Lydia is also chair of the Citizen Mobilization Workstream of the Ministerial Advisory Committee on Social and Behavior Change. Over to you, Lydia.
Leanne, thank you very much, and thank you for that kind introduction. I'll just share my screen, and there we go. So thank you very much, and thank you for this invitation. I'd just like to acknowledge Noe as a one-person health promotion dynamo in her community, and the incredible work that she does through the health committees there as well. And when Jane and I sat together and we chatted on the phone, of course, it being COVID times, as we discussed what my contribution to this webinar could be, I really thought bringing together the aspects of community and my work as a clinician during this time, and my reflections on how that can draw lessons for us around health promotion, and also give a sense of how COVID-19 has changed the ecosystems and how we interface with patients, families, and communities as the health system. So much has been said about this, but I think it's worth a brief reflection that COVID-19 is unique, but it's unique in its unforgiving spotlight on our society and the spotlights of our global society, not only South Africa. Very few illnesses, in fact none, have brought countries to the brink, closing schools, workplaces, and actually very large sections of the health service have been closed during this time. It's also a stark and damning reminder of how if you fail to address the social determinants of health, you cannot address any health issues successfully, and specifically a health issue such as this, where prevention is so primarily our key intervention. It's also forced us to see the unseen. It's forced us to see the poverty, overcrowding, the lack of water, the broken schooling system, the fragmented health systems, how our food industry remains profit-driven and not people-centered, the vulnerability of women and the conditions in our prisons. And all of these things have come up and really bubbled to the surface during this time. So COVID-19 has really been an intensely political time, and is intensely politicized. And I was reminded of how health is really part of a much larger social and economic fabric through debates on platforms like the C19 People's Coalition, where health was just one of many, many working groups working around a range of issues from food security, income security, women's rights, labor rights, etc. And health was one integral part, but was not the only focus. And that is really an important lesson for us to take forward around that. So how does that relate to what happens to a patient when they come into the hospital? So because it has been subjected to such intense public scrutiny and so much has been written and said about COVID-19, the diagnosis, the positive test, a PCR test coming back and that SMS coming on your phone that you have COVID is loaded with all of this context. And so it feels different to getting the diagnosis of another illness in this time when the whole world is really focused on this virus, which is now in your body. So the hospital experience, even in the best clinical environment, and we know that some of our hospitals do have a good clinical environment and many don't, but even in the best clinical environment, the diagnosis of COVID-19 comes with tremendous fear and anxiety, even amongst very well-informed people. That's the first response, is a panic. And patients that come to us, there's this strange mix of being very, very, very profoundly ill, mainly a respiratory illness, with people being profoundly hypoxic and very oxygen dependent, but at the same time very alert and very aware of what is happening around them, and also the deep sense of their own imminent possible mortality. And if you think then that against the backdrop of that intense social and political context of the COVID-19 run-up that we've had, because in South Africa we had a number of months of run-up before we really hit the peak. So if you put those two things together, and then the very long admissions that are required, so many of our patients are in hospital for weeks before they are discharged, and of course some don't make it. And so these long admissions at the very limit of human survival has got a profound psychological impact. And then if you add to that the fact that family and friends cannot visit, this is a massive trigger for depression and anxiety, and that the physical contact, which is a normal human interaction between health providers and patients, is gone. So we are masked and we are gloved and we have aprons and gowns and visors on all the time. And so there's that lack of contact at a physical level. So really at that sort of individual patient level, COVID-19 has called for higher levels of compassion, psychological support, and solidarity with patients who are going through these experiences. So how have we begun to see how this impacts on what we can do for health promotion? And it's really only through reflecting on that clinical experience and I suppose the community engagement that I've been doing, that I can see that the person who is ill with COVID in the hospital and then goes back into whatever community they return to, we must use community in the broadest sense, goes out as a powerful and authentic messenger. And it's really important that we spend time making sure that we have brought together the correct knowledge package, if you wish. And we know through the HIV pandemic and our experience with that, or epidemic in South Africa, that for knowledge to be empowering, it needs to be deep and it needs to be integrated and it needs to be something that's repeated and in the form of a dialogue. So with patients in hospital, it's really important, and this is something that we've learned from COVID, but of course it should apply to every illness, is the detail of what is happening to someone when they are there is something that they need to understand, how the lungs work, why oxygen is so important, why they need to lie on their stomachs, why they need to do breathing exercises, what does it mean when your blood saturation level changes, how to check your monitor at all times. This empowering information is then going to be translated when someone goes home and communicates with family and friends and then a wider range of people beyond that. And I've got here two pictures. The one is of a patient of ours who was in hospital for 77 days and was ventilated for 51 of those. And she actually danced out of the hospital at the end. And, you know, that's a very authentic and powerful message about how you can recover from COVID, which is an important message because there is a sense that once you are admitted with COVID that everybody dies, which we need to really work around as part of the stigma. And the second image is a number of our patients who came off high flow oxygen and were subsequently discharged. So some of those are the positive stories, but also that patients are empowered with the correct knowledge when they go out. So moving to the next layer, which is the family experience, and really COVID-19 has exposed the failures of communication within our health system, which we know are there, but have been exacerbated by the isolation of patients in hospitals. So the issues of phones not being answered in wards, information not being given consistently, relatives being moved from ward to ward without any communication, or even being admitted and the family is not aware that the COVID result is positive, which has implications for isolation and quarantine outside. And I've mentioned that the lack of visiting is a real issue. So this then places families in a position where they are really desperate for information from health workers. There is no other way for them to check on their relatives. And health workers, and I'm one of them, so I know, are stretched and overstretched and exhausted, and communication with families is often not the most important thing for them to do. But the results are profoundly problematic if that communication does not happen. So even if a patient is discharged and they are well and it's a positive outcome, a lack of communication during the admission can taint that positive message and can taint the information that comes from that admission. And secondly, when patients die in hospital, where there's been poor or no communication, families are inconsolable. And this is leading to a lot of complicated bereavement. And our psychiatrists tell us that they anticipate an epidemic of complicated bereavement after this pandemic in the next couple of months, weeks to months ahead. So what if we tried to do, and what have many hospitals done? So COVID has pushed us to focus much more on family communication. At a number of levels. So family advice sheets have gone out on WhatsApp and other platforms so that when a loved one is admitted, they know that you need to supply correct contact information, designate one family member to be the contact person, make sure that your loved one has a phone that's functional, that they know how to use it, that they've got a charger and data. And of course, for patients that don't have those things, many phones and a lot of data has been donated by many organizations to different hospitals. So the family preparation is important. And then through COVID-19, there's been the establishment of psychiatry, social work, and palliative care teams working together to support clinicians with family communication through family video calls, as well as post-bereavement counseling. And this is really important because after a death, there's often no communication with the hospital. And that's actually when families really need to unpack the many questions that they have. Within our clinical service, we have implemented in some of the wards, and I'm sure all over the country, what we call communication ward rounds. So part of what we do is to see patients and to look at their treatment, but part of that is also to phone families. And that actually has to be done by the clinician managing, because without a detailed knowledge about what's happening with each individual patient, you can't really field the questions, because those phone calls might start off as your relative is doing well or stable today, but ultimately they become education sessions where we talk about what does COVID do when it goes to the lungs, how does it cause a pneumonia, how does it spread, how do we interpret how much oxygen a relative is on, how do we know when they're getting better or getting worse, what should I do now that I'm at home with my small children, how should I isolate from them, do I need to quarantine my neighbor because they were in touch with me. So you can see how that communication with a family member has a ripple effect of knowledge going out into the community about the virus and about what to do around it. And of course, if we establish good communication, then we build relationships of trust. And if there's a positive outcome, it is a cascade effect of knowledge. And if there's a negative outcome, or if a loved one dies, there is a sense that there's been empathy and compassion and an individualized approach to their treatment. So coming to the third aspect of the three layers, so the personal, the family, and the community. So coming to community, and this really speaks to my work more with the People's Health Movement. I suppose the problem statement would be that there's been a lot of information around coronavirus. I don't think there's been anything in my memory that I can think of where there's been more information. But information does not equal education. It does not equal understanding and knowing. And I think part of the problem is most health promotion has been digital, television, WhatsApp, videos, webinars, YouTube, and so on. And digital messaging has limitations. It has limitations in that there's a lack of dialogue. So for example, in the community engagements we've been engaged with, we've discussed home remedies for COVID, and the issues of umhlonyane has come up. And this is a very, very commonly used home remedy, actually, which many, many, many people are using. And we need to know more about that as medical professionals and look at it closely. There's a lack of context to digital messaging. So when people are asked to isolate, it's met with deep cynicism by a number of communities who are living in overcrowded spaces where self-isolation is simply not possible. So how do you then translate that to mean something in a community? That can only be done really with dialogue. And then thirdly, and I think this is really important, is that there's a lack of feedback into the public messaging machinery, if you wish. So we're giving messages from the Department of Health with health workers, but we're not getting feedback about what might be happening on the ground. So for example, on the issue of masks, we've heard some really terrifying stories about, so the shopping center won't let you in without a mask. And so if you get there without a mask, you ask someone if you can use their mask so that you can get in. Or even that there are people renting out masks that you can use to go into the shops and then you give it back when you come out. I mean, these are the kinds of things that we need to intervene on and make policy decisions around. And then the issue of translation. So some of the communities struggle with, you know, how do we translate some of the COVID language like quarantine or isolation and so on. So that feedback is important for how we re-engineer our health promotion campaigns, even at the digital level. So that can only be provided in dialogue. So really we're talking about health promotion from the bottom up, which I think is the third circle. And for me, this needs to happen through small group workshops as a one step in the process. We model best preventative practice through the actual workshop. We have dialogue and knowledge sharing. And importantly, from there, we have action from knowledge. And there's some really amazing examples of this work that's been done actually with a health promoter, Eleanor, I'd like to acknowledge her, and some workers from MSF, Mpumi and Tom and others, who've actually set up a community COVID response team. They have volunteers who help with distributing sanitizer, jig to taxi ranks, and health promotion messaging at hotspots in the community. So it's a popular education process. So it's knowledge in context, translating into action. And we will need this for a while. So it is worth setting up and promoting the local health promotion partnerships, because we know we have HIV, TB, diabetes, hypertension, cancer, and we know that COVID will not disappear. And we also know that we may have new viral pandemics in the future. So this is my second last slide. I just wanted to highlight where I think we can put our resources and our energy, which might be a gap in our health promotion campaign. So right here at the top, health committees, health promoters, and community health workers. If you think about the health promotion partnership between health facilities and communities, the bridge between the two of them, it actually exists already. But the bridge is under-resourced and under-promoted and under-recognized. So health committees are statutory, legislated, but they are not resourced and they're not supported, and we need to establish our health committees. Health promoters are not recognized in all of our districts. They are not employed in all of our districts, and they're not recognized by the HPCSA. This needs to change urgently. And our community health workers, I'm sure all of us have seen in the media the battles and struggles for community health workers to get adequate remuneration, to be adequately trained, and to have recognition as health workers within the health force. And if COVID-19 can give us something, surely it should be to give us stronger bonds and links between our health facilities and our communities through these three structures. And so in conclusion, what are the lessons for health promotion from COVID-19? Essentially, patients can be catalysts for positive messaging, families are part of the therapeutic team, and communities need direct engagement and building of partnerships. And really for me, this pandemic is a clarion call for a patient, family, and community-centered health system and for a strengthening of the primary healthcare approach. Thank you.
Thank you very much for that.
Leanne, I can't hear
issues
you.
which I hope we can take forward in the discussion. Can everyone else hear me? Hi. Hello.
Yes, we can hear you.
We can hear you now.
Okay, great. Thanks. I was just saying, Lydia, thank you so much for that presentation. It was really great and powerful, both in terms of what you're facing, in terms of the clinical coalface of COVID-19, but it also raised for me, in particular, the issue of using patients who've recovered as advocates and as health promoters. I think that was really a powerful message. It also highlighted for me how important it is to have people who are clinicians like yourself, also interfacing with what's happening at the community and recognizing the huge mental health burden that this is having, both on patients, but also on their families. And it seems to me almost like there is a secondary population here of family and friends for whom we already know would be a population for a mental health pandemic, and that perhaps we need to be responding to that proactively rather than reactively. So thank you so much for that, Lydia. We are going to move on to the last speaker, and that is Professor Sue Goldstein. Sue is well known to the field of health promotion. She is a public health specialist who's worked as a program executive at Soul City, the Institute for Social Justice, for over 22 years. She's also medically qualified as a doctor, and she specialized in community medicine at the University of the Witwatersrand and has 23 years of experience in public health and in particular in health promotion, advocacy, and communication. Sue helped to develop the health promotion track called the Social and Behavior Change Communication track in the Master of Public Health program at WITS. And she has focused on health communication and has been one of the originators of the Soul Buddies children's television drama series and the Soul Buddies Club social mobilization intervention, both for children 8 to 12 years old. A recent retrospective evaluation of that club, the Soul Buddies Club, showed a 50% decrease in HIV rates among Soul Buddies Club members 10 years after being members, compared to their peers who were not members of Soul Buddies. In 2008, Sue joined the SAMRC WITS Center for Health Economics and Decision Science as a deputy director. And she currently also teaches at the School of Public Health and supervises masters and doctoral students. Sue, thank you very much for joining us. And Sue will make the case for a health promotion foundation. So over to you, Sue.
Thanks very much, Leanne. Can you see my screen?
We can, yes.
Sorry for sharing it early, but I get anxious that it won't work. So apologies, everybody. I didn't mean to rain on parade. Well, first of all, saying thank you very much to all the previous presenters. I hope I don't repeat too much of what has already been said. And I see I put the date wrong. It's not the 5th, it's the 7th of August today. So apologies for that. I'm going to talk about Health Promotion Foundation and the links with COVID-19. But I first also want to acknowledge the National Health Promotion and Development Foundation Network, who has been working on this, trying to get a National Health Promotion Foundation going for a long time. And to thank all the participants who are on the line now. It's certainly
I don't understand what this means, but it's teaching grandmothers to suck eggs, which basically means that I'm telling people who know more than me what's what. So please forgive me, everybody, if I mess up. Okay, so just what is the context that we're dealing with? We're dealing with the most unhealthy country in the world, ranked by a whole range of scores. So if you look at spending, we're quite high on spending compared to the grey one is Canada and the white one is South Africa. So we're spending a huge amount, but look at our outcomes. Our blood pressure is incredibly high. We've got very poor obesity stats, lots of depression, very low happiness, high tobacco, lots of inactivity, etc. So 16% of government spending goes to health. But in 2019, this was the picture of us being, out of all the countries that were measured, we were seen as the most unhealthy. We also have the highest inequity. This picture always is a kind of horror picture, if you like, of the contrast across the roads. We have health sectors. So we have an overused and overserved private, high-cost private health sector, and I argue also not a very good one. And we have an under-resourced and highly challenged public sector with poor facilities, understaffed, oversubscribed for people, etc. And poor management often as well, I must add. Our country is trying to move towards universal health care. We're looking at the NHI is really a mechanism to buy health services. And in the NHI bill, it includes prevention and promotion, but it isn't clear how it's going to include promotion. And the question we have to ask ourselves is, can the NHI be a success with a quadruple burden of disease? And my answer is, and this is what I'm going to try and talk about, is we can only be a success with a strong health promotion program, which will decrease the burden of disease. Now, there's two things that I want to say about, before I move on, what health promotion is. Maybe I should say what I think health promotion isn't. So the first thing that I would do is ban two words from this conversation. The one is messaging. I don't like the word messaging. And the other is behavior. So I think that those two words really create an environment in which we don't understand what health promotion is and what it can be. Messaging is just sending messages at people. That is not communication. And behavior is an individually focused thing that really takes place in a hugely important context. And I know that people have spoken about it, but I think that we kind of slip backwards into this discussion about what behavior is engaged when we're talking about health promotion. The other thing that health promotion isn't is social and behavior change communication. Health communication is one aspect of health promotion, and it is one aspect. I think what I would like to say is that health promotion is a comprehensive social and political process. It is a catalyst for action directed at changing the social, environmental, and economic conditions to alleviate their impact on public and individual health. So very closely related to what Lydia was talking about, the social determinants, and in fact, all the other colleagues were talking about it. But it comprises actions which strengthen skills and capabilities of individuals and communities to increase their control over the social determinants of health and well-being, and creates an environment in which this is possible and can take place. And then we have enter COVID-19. And what happened with COVID-19 has been really interesting to me, as a person who has been involved with the HIV/AIDS epidemic and with health for many, many years, measles when I was much younger doing my clinical work. And what happened was there was an all of government response. And this really fascinated me. And I think this is really what we've been hoping for in health promotion. What the COVID-19 epidemic has also done is, as Lydia said, it's emphasized the need for addressing the social and economic determinants of health. You can't wash your hands very easily if you don't have running water. You can't isolate in a shack. In fact, it's very difficult to do a whole lot of the behaviors under the circumstances in which people live. It's hard enough when you live in comfortable circumstances, as many people on this webinar will agree. What's also interesting is it means that we've had to have policies in all sectors. And although these policies have been developed at very, very rapid speed, it's just been interesting, and there have been many mistakes that have been made, let's face it. But policies there have been in all sectors to deal with the health issue. It's been in the transport sector, in the DTI, in all sorts of sectors. And I think that this is what we would be hoping for around health promotion, that health will have policies in every sector. I just want to mention here that I know people are going to talk about SANAC and the National AIDS Council, and surely that is the kind of mechanism that could work for an illness. And I think there are two problems with the South African National AIDS Council. The one is that it is very disease focused, which health promotion shouldn't be. But the second thing is that it's what happened with SANAC is that people started teaching people about HIV and AIDS in each sector. So you had the same education response in each sector, instead of actually the sectors doing their jobs and making sure that environment was possible for the social change. So instead of teaching young girls that they shouldn't have sex at a young age, really, we should have made sure that all those young women had access to school, had access to social grants, etc., etc. So for me, that is the big difference around what we see as health promotion. And then one of the things that's been mentioned many times in this webinar is that we are only able to control COVID-19 with non-pharmaceutical interventions. So it's dependent on behaviors, norms, living conditions, transport, social security, water, etc. See, I even use that word behaviors. It's dependent, take it out, take that word out. So what have we learned about health promotion from other countries? We've learned a lot. So the Thai Health Promotion Foundation, which we draw on a lot because it is a lower middle income country, was established in 2001 to decrease NCDs and support the national Thai health introduction of their health insurance. And they achieved universal health coverage in 2002. The health promotion foundations, there are many in a worldwide. So there's the Victorian Health Promotion Foundation, Western Australian Health Promotion Foundation, the Thai Health Foundation, Malaysia, Korea, Tonga, Taiwan, Singapore. But this is not a Western idea. This is really across different countries in the world. But I wanted to just talk briefly about the big health story because it was the one that convinced me many, many years ago about why we should be having health promotion foundations. And really the health promotion foundations in Victoria was that the impetus was the smoking, trying to get rid of smoking advertising. And with the new laws around tobacco and advertising, there was a lot of question. How are we going to deal with advertising? What's going to happen to sports sponsorship? What are we going to do? It's too awful. The industries are all going to go under, and Yusuf will know these arguments came out in South Africa as well. But what happened in Vic Health is they developed a health promotion foundation and they were funded by the excise tax that came from tobacco. And they used that funding for advertising, for healthy advertising. And this is just one of the examples of a billboard that they put up. But they sponsored sports. They would have HIV, safe sex, football games, etc. So it was used to fund what people were anxious about, losing jobs, etc. So what is the Health Promotion and Development Foundation? It's a statutory foundation established by an act of parliament that uses funding from dedicated sources to support and encourage healthy lifestyles to prevent illness and reduce the burden of disease, which is what we need for the NHI to function. What are the benefits of a foundation? So of course it supports government priorities, which are to have a healthy and wealthy nation. What's important, and we often forget this, is that we are able to work multi-sectorally in a health promotion foundation. Many of the people on this call are from the health sector, and we need to be having many more from other sectors, from law, from spatial planning, from all sorts of other sectors that need to be involved in helping us to develop healthy environments and healthy laws. It can work across non-governmental, private and public health sectors at the same time, which is very difficult to do if you are in government. There's less bureaucracy than government and a more rapid response time. It can advocate and coordinate an all-of-government response to address social determinants of health. And it can address issues with industries such as the food industry, tobacco, alcohol, transport, entertainment and sports industries, amongst just a few, to address health issues, And sorry about leaving it off the slide, but it's very difficult for government to address these issues with industries, and we need to be able to have independent advocates to do that. So what is about funding of the Health Promotion and Development Foundation for South Africa? Well, first of all, you need a dedicated, reliable and consistent funding stream. So currently what happens at the moment is health promotion is a very small, pardon me, Lynn, department in the Department of Health, and gets very little funding at the national level. I'm not sure if there are health promotion units at each provincial level. There are some in some provinces, but not in all provinces. And it's not consistent, so it depends on the health budget at the time. What we thought is that you could have an additional 2% levy on alcohol and tobacco products, which could be used to fund the Health Promotion Foundation, and which could also improve, decrease access to alcohol and tobacco products at the same time. And we can add in sugar, sweetened beverages there as well. It will, and that gives us double benefit. The other point about this is that it's a polluter pays. So the principle that the polluter pays is really important, that it's not just us, government and the taxpayer, that end up paying for all the harm that's being caused by these harmful things. And I think I need to point out that big food is in there at the same time. It will reduce costs to health system, transport, social development, police, justice and correctional services, etc. And it will increase available resources for sports and other pro-health and development activities. But just to give you an example of other health foundations, their population size, their annual US budgets, and what the annual budget is per person in US dollars. And where they get their money from. So the source is from surcharge on tobacco and alcohol in Thai health, value-added tax in Australia, in Korea, tobacco excise tax, in Malaysia, treasury budgets, and in Switzerland, it comes from the health insurance. So what will the Health Promotion Foundation do? The first thing, it will encourage and fund health promotion research. So it won't just be around what in the fields that we think are health, but it will be in all the multidisciplinary areas at the same time. So we would look at funding policy research, we would look at funding spatial planning research, etc., farming, whatever we needed. It would coordinate priority setting in the field of health, and it would support and coordinate existing community-based activities. So the one pillar of health promotion, which I believe has always neglected, is community action. And what Lydia was talking about, activating communities and linking them to health services, but also to other services, and getting people literate, as at the bottom, talking about health literacy, I think is critical. And the Health Promotion Foundation would also start negotiating with sectors to make sure that we have health priorities in all policies. And then finally, what I just want to say is health promotion is making the healthy choice the easier choice. And whether that comes through messaging or it comes through creating an environment that makes it easier, that is the bottom line, is really to try and get it the easier choice, not to berate people for behaving badly, but to make it easier for them to behave well. And the final question that I think we all need to ask is, where do we go to next? And I'll stop there. Thank you.
Thank you very, very much, Sue, for that comprehensive overview, and also for making the case for the Health Promotion Development Foundation. I think your question was a perfect segue into the question and answer session. And if I look in my question and answer session section, I do have two questions at the moment. And I want to encourage everybody who has a question to any of the presenters, or a general question around this webinar, to please type it in the question and answer section now, so that we can take some questions. At this point, I'm going to open up the floor for questions and answers. I will first just give you a sense of the questions that we have, and then we will see who is wanting to actually respond to those questions. But please do take the opportunity to ask your questions now about this very important area. So the first one is from Sky Grove, and Sky asks, says, thank you very much for the insightful presentations. I would really like to hear your views on COVID-related behavior fatigue, especially in light of increasing structural realities like poverty and hunger. So I'll just give anyone a chance at this point to indicate if they want to answer that. And while you're thinking about whether you'd like to respond, the second question is from an M. Jose, who asks, what would be the key impact indicators for the Health Promotion Development Foundation's effectiveness to be measured over time? Would any of the panelists like to respond to the question? I see Sue's hand up. And Sue, can you just indicate if you want to answer the first or the second question?
Hi, I'm happy to try both, but I'm happy to do the first one though. So the first one is really about COVID-related fatigue and the living context. And I think for me, I don't really link the two. I think that if you're hungry, you're hungry, and it's not about COVID fatigue. It's about the reality of how you have to live. And I think our job is to look at and to go to people in communities and ask them, how can we make it possible for them to stay safe from COVID, rather than telling people what they should be doing? Because I don't believe that any of us could stay safe in the context that many people are living in.
Thanks for that, Sue. Do you want to have a go at the second question, or is someone else on the panel that would like to answer it, relating to the indicators for the effectiveness of the Health Promotion Development Foundation?
I don't mind trying, but there are quite a few people on the call who could also answer if they wanted to. I think that it depends on what the foundation sets up as its objectives at the beginning. So, for example, if it's really to focus on decreasing NCDs, and in that process decrease harmful consumption of alcohol, decrease consumption of tobacco, decrease obesity, whatever we're aiming to do, then those would become indicators of success of the Health Promotion Foundation. Increase literacy of people, improve engagement with communities. I mean, those are all ideas that could be indicators for the NHPF.
Sure. Thanks for that, Sue. I have another question, and this one is directed to Lydia. Lydia, I see your hand up. I'm not sure if you want to respond to Sue's previous questions and add to that, or do you want
wait,
to?
Leanne. I think
Okay.
just carry on. And
Okay, so there's this question directed specifically to you, Lydia, and it says the approach, it comes from Greer van Zyl. It says the approach to communicating with patients and families, seeing recovered patients as authentic messages. How did this arise? Are clinicians routinely educated about communication, or was that a unique situation?
Thanks very much. I think I just wanted to comment on the question of fatigue first, and I think it's a really important question. And I think we have to find a way to reach a steady state where the behaviors or the actions and the way that we move around as citizens and as communities, that we incorporate preventative measures in what we do, and that it is something that is possible to do over a longer period of time. So, for example, staying home is not possible to do forever. But wearing a cloth mask, particularly if it's freely available and a high quality mask is made easily available, and everyone can have several masks, that is possible to do. It is possible to avoid large crowds and crowded indoor spaces. So I suppose what I'm saying is we need to refocus our messaging or our communication to look at the kinds of actions and practices that are sustainable over time. And I think practices such as small meetings rather than big ones, outdoors rather than indoors, masks, sanitizer should be freely available. You have a little bottle of sanitizer in your bag or in your pocket. Those things we can do in a sustainable way. But I agree that the stay home message is something that we have for our peaks. And when we're going off peak, we need to think of something we can do long term. Around the second question, thank you for that. No, we're not formally taught communication as clinicians. Unfortunately, we really should be. There's possibly in the newer undergraduate program a few lectures or talks on communication. So it's very variable. I don't think that this is the only hospital that's focused on family communication in this way. I think that there are many facilities doing that, but it is patchy, and it does very much depend on both the human resources and the knowledge of what to do. Like any kind of change, it's both knowing what to do and having an enabling environment. So we had phones that were donated, and we had available social workers and very enthusiastic palliative care team. But then you also need senior clinicians to, and if I don't go to the ward for a day or two, people forget to do the communication ward round. So we kind of have to constantly monitor and support the processes and the changes that we do. But it is something that I think that COVID has really spotlighted for us, and it's an opportunity for us to standardize and I suppose expand that to all illnesses, not just COVID.
Thanks, Lydia. If I could just also take the liberty as chair to say I've been really fascinated by that example, and it raises for me two issues around the health promotion pillars. The one being reorienting our health services to look at the patient as just beyond just being an individual, and training clinicians also to be able to do that. And your responsiveness to that, and the anecdotes from what effect that has had, has certainly proved that to be something to be very important. And also providing a supportive environment and creating a supportive environment to ensure that these things are done. So I'm really excited about that, and we do take our hats off to you and extend our great appreciation for the sensitivity to that in your current clinical practice. There is another question from Sibusiso. And Sibusiso, this is for you, Lynn. He wants you to please brief us on the human resources in health promotion. Is there standardized HR throughout provinces, and are there qualified health promoters?
There are no standards in all provinces, and there are many provinces where you don't have qualified health promoters. And this remains a huge challenge.
Mm-hmm.
We had at National started a process of trying to motivate for capacity, for increased numbers, for training. Even the issue of registration, which was highlighted earlier.
Yes.
Some of these issues end up as at a level where we can only motivate, and if there is no willingness and there are other priorities, you may end up your issue being put at the back. So there is a challenge with capacity, both in terms of numbers and in terms of qualification. If you remember, long ago, we didn't have people who were trained in health promotion. So we had various health workers, some even being called health promoters, moving from being a community health worker or an educator to being a health promoter. So there was a period when we tried to do an assessment of what exactly is happening in the whole country. Mm-hmm. And we managed to get a report that we have qualified people who are moving from various careers and joining health promotion out of interest. And then we have the ones who were moved up from being health educators. So we do, just to respond to that, we have a huge challenge.
Yes.
And this issue depends on the leadership at a certain point in time, who may see it as an important aspect and some may see it not as an important aspect. So that's the challenge. I don't know if this is answering Sibusiso adequately.
I think it is, and it's also related a bit to Ferdinand's question, but it's actually directed to the Health Promotion Development Foundation. And Ferdinand wants to know whether the foundation has been involved at all in getting health promotion to be recognized by the HPCSA in other countries, and can they champion this in South Africa? Anyone wanting to respond to that?
Maybe I can just touch as well a little bit on the issue of registration of health promoters. There was an initiative from our previous minister to communicate with HPCSA to register health promoters. And the assessment or the audit which we conducted was supposed to support that process. Mm-hmm. And then there were changes again within our own system, which I would not necessarily want to discuss in this forum.
Sure.
And recently there have been questions again about visiting that initiative. We are hoping that there may be appetite with the new leadership to restart that process again. So I don't think it's a process that has been forgotten, and the delay in that, it's not from officials, because the officials who are working in health promotion do want to be registered. So there are bottlenecks which at times are beyond one's control in terms of how we move forward.
Sure. Thanks very much for that, Lynn. Nozipo is asking, is commenting and has a question. Says, thank you very much for these informative presentations. What strides are we taking to make government take health promotion seriously beyond COVID-19? We have a lot of health promotion master's graduates from UKZN at the moment, a workforce that we are not utilizing. And how do we bridge the gap between facility-based healthcare providers and health promoters? Sue, is your hand up to respond to that?
Yes, it is. So I think it's a great question, and I still think that there's a lot of crossover and a lot of, what should I say, misdirection around what health promoters can and should be doing, and what is health communication and social and behavior change communication. And I think the conflation of these two areas puts health promoters in a very difficult position, and they end up being what people think of as frontline communicators. And they really are not able to engage cross-sectorally with their people in their various other sectors, like even in health, for example, with environmental health people, etc. So the answer is, it's a very good question, and I don't know. I think that we need a lot more advocacy and a lot more lobbying around getting health promotion understood, and really looking at how it can be funded. Until it's funded, people are not going to be able to do anything. And currently, in my view, that's part of the issue.
Thanks very much for that, Sue. Just a comment related to that from Anna, saying that environmental health practitioners trained in health promotion, many are unemployed because they cannot get community service posts which are not available. And so I think that is a familiar story for a lot of people who are formally trained even in health promotion. There's a question to you, Jane, from Peter, who says, I would like to know if, as Jane argued, COVID-19 is influencing the thinking at national level about the need for NHC, and if so, at what level would this be proposed, perhaps to Lynn? So it's directed to both Jane and Lynn. Jane, do you want to take a go?
So I think I'm understanding the NHC to stand for the National Health Commission, which was a structure that was originally suggested by the National Health Insurance Fund in the one of the original papers, and as an implementation structure. This structure is no longer in the NHI bill. And one of the things that Professor Parry and Professor Freeman and I presented to the ANC study group on health promotion and the need for health promotion with regards to national healthcare or universal healthcare in the NHI would be to look at either reintroducing this National Health Committee or the equivalent of it, which would be the HPDF. So not the equivalent, but a similar structure. So there could certainly be both, but I'm not sure what the one would be more independent. But so there is an interest in talking about the interest of the national of health promotion with universal health coverage, or NHI. Lynn, would you like to answer?
I might have missed a little bit. You were trying to explain the process and where you presented. Can you tell me the last part?
So, Lynn, I'll just fill you in. If a health promotion, I beg your pardon, I need to just catch my breath for a second. If health promotion is going to be influencing national level thinking at the level of the NHI in this instance,
Okay.
at what level would it be proposed, perhaps within your departments? What implication would it have? That's my understanding of the question.
My view is that, I mean, at the moment, we have had health promotion at a director level, but for the past 2-3 years, we could not even fill the post because at the time, I wouldn't even touch on those details.
Sure.
But for me, it's not even about a level, it's more about the recognition of health promotion as an important aspect of health, and the director level could be the minimum, but if you decide to bring it up higher, it could go up. But for me, it's that important. But health alone, no matter what level you put the position at, health alone would not be able to address health promotion issues in the country.
Absolutely.
Meaning that the issue of a foundation is very critical.
Mm-hmm.
And we acknowledge that. Because even amongst ourselves as we are, I mean, at the moment within health promotion, as we had discussed earlier, it's more about, do we have qualified health promoters? One of the, I mean, I would say at the moment, not everybody that is working within health promotion is qualified as a health promoter.
That's
that
right.
alone is a gap. Then secondly, when there is a reduction in staff numbers, when someone resigns, that post is not necessarily filled immediately. So it means every time you lose a person, you lose the warm body within health promotion.
That's right.
So at a national level, you don't have a full staff establishment. At a provincial level, there are provinces that only have one person as a health promoter, and everybody else is supporting. So there are huge challenges. There are provinces that have managed to acknowledge that gap and have sorted it out. But we still need that commitment that health promotion is different from health education, is different from community health.
Yeah.
So that for me is a major challenge, and it is important for, I mean, we tried to put a document that tried to address the differences between these categories, because people were looking at a health promoter as somebody who can go door to door to educate people. Yeah. And we are trying to say that is not what a person with a qualification like this should be doing. There's much more. There's analysis of situation, analysis of, you know, we try to package it in a way that I mean, a health promoter could get the necessary recognition that they deserve, and a country to realize if they were to prioritize this, they would actually benefit a lot in terms of health outcomes. But it's challenging.
It is.
Yeah.
Thank you very much for that, Lynn. We only have about 5 minutes left, and so I just want to quickly flag 2 comments and perhaps take 1 or 2 more questions before we have to conclude. Just acknowledging Vina Abraham and Pindile's messages, saying, expressing their appreciation for the mentioning the impact of COVID-19 on mental health, because it's often overlooked. So thank you very much for that recognition. And Pindile is saying that they feel the establishment of a health promotion foundation will be of much use and a very powerful force in driving home communication. And so I think those comments are really important for the panelists to hear, because I know that for many people, it's been a struggle to try and get this on the agenda. And then there's also a question from Charles Parry. Charles would like to know, how effective are we in getting the messages across about the value of health promotion to key gatekeepers in Parliament and in government at all levels, and even the media? I suspect that most of the people watching this webinar are among those who believe in health promotion, and we need to reach a broader group of stakeholders. Is it the private sector that's doing better than the public sector in this area? And I'm going to leave that open to anyone on the panel who'd like to respond to that.
Hi, can I come in there, Leanne?
Go ahead, Sue.
Thank you. First of all, Charles, I think you're right. We're preaching to the choir, if you like. I think that we aren't so good at getting our message across, and partly it is because we work in silos. So Charles works in alcohol, Severa works in tobacco, I work on sugar tax and food, and we don't really pull it all together in terms of how it can all work together. So for me, that's the kind of thing that we really need to be able to do. We were trying to do that through the Health Promotion Foundation network, but not being funded, and people got really busy and didn't have time, and it makes it very difficult when you're doing more than one job at a time. I think just to talk a little bit about Lynn's, and forgive me for calling you Lynn, Lynn, that's how I know you. Lynn's response is exactly why we need the Health Promotion Foundation, because the Department of Health has such competing priorities. It has to, it's health promotion will never see the light of day within the Department of Health, and that's why it really has to move out to a separate place and be properly funded. And I saw that there was one more question just to add to that, is the health promotion levy allocation from Treasury. Could that not be used to facilitate the establishment of the Health Promotion Foundation? And I'll throw that out for everybody else to answer.
Thanks very much, Sue.
First, maybe.
Sorry, is that you, Lynn?
Yes, I wanted
Go
to
ahead,
say the initial proposal for the levy, which we had drafted with Mel when she was still in the department, when he was still in the department, a big chunk of that was supposed to establish this foundation. But again, it was on paper. It was a motivation on paper, and Sue has just indicated that there are conflicting priorities. The foundation, I'm just wondering whether do we foresee the foundation replacing the unit within health that will be responsible for developing policies? Because my view was that the foundation should guide the policy development which happens within government, but they will be the implementation agent for the department. And maybe that's a discussion for another day on how we view the role of the foundation, should that be accepted one day.
Thanks, Lynn, for that. Certainly lots of conversations that will follow this webinar. I want to take a question from Severa. I know Severa Kaladin has been involved in Health Promotion Development Foundation efforts for a while. Severa, do you want to sort of speak to your question? Severa, are you able to unmute? Possibly not. So while Severa is trying to do that, Rufaro Ngulube. Rufaro, do you have a question? I see a raised hand from you. Okay, neither of them. Perhaps I would encourage.
The attendees can only respond via text. They cannot.
Okay. So I want to encourage both Severa and Rufaro just to type in your questions, and we, if not able to answer it now, we will do so perhaps following this. And then there's a question here about how can the health promotion levy allocation, okay, we have touched on that. It's from Adila about the levy and how it can be used by Treasury to facilitate the Health Promotion Foundation. Colleagues, we have come to the end of what I think has been a fantastic opportunity to engage on the issue of health promotion with a range of really diverse and very well qualified individuals from all the sectors. And in fact, this should be a snapshot of what health promotion should be about. Working together with clinicians, with people who work at the coalface of communities, people within government, etc. And this is ideally what we're striving for in the pursuit of health through health promotion approaches. This webinar was actually put together by the special interest group of the Public Health Association of South Africa, PASA. And so to conclude this webinar today, I want to hand over to Ishak Date, just to convey a vote of thanks. Over to you, Ishak.
Thank you so much. Thank you, Leanne, and thank you to all the participants and the speakers. I think it was really exciting. And yeah, it's an honor for me to share this platform with all of you. Um, just one word on the SIG. We've kind of restarted or relaunched the SIG about a year ago. And what we're doing is we have a Google group, and we also have I've had a series of webinars. This is one of them. We've had a previous one on alcohol, and we're looking forward to having a webinar on nutrition and the NHI. Just to encourage people to take part and be active, we really need all hands on deck when it comes to health promotion. So just in giving thanks for this webinar, I want to thank FASA and the MRC for facilitating the logistics of this webinar happening. Also to say that the SIG, we do have a space on the FASA website. So please, for future webinars, please watch that space. I want to thank Leanne for doing a great job of chairing the session. It's really an honor to have you on this forum. Thank you, Jane, for the excellent critical overview of health promotion and behavior change in South Africa. Lynn, thank you for translating what this means with regards to the COVID response. And I really like the model that you presented, and I think you should strongly consider developing it further, and we can potentially use it in our health promotion teaching. Now, just to echo what Lydia said, I really think, real dynamite and giving us a grassroots understanding of what is happening with regards to COVID. Lydia, thank you for combining your activist and clinical hats and giving us a real sense of the COVID pandemic and how we can care for families. And Sue, thank you for bringing in the perspective of the Health Promotion Development Foundation and speaking of a very important gap and how the government can potentially fund this gap. So thanks everyone, it's really great, and looking forward to seeing you at the future webinars.
Thank you very much, Ishak. And I think it remains for me to say thank you very, very much to all of the panelists for their fabulous presentations and also for engaging in the question and answer sessions. And thank you to all of you for participating in this webinar, the success of which would not have been possible without your very interactive and insightful engagement in your questions. We will continue to keep you updated on further webinars. Thank you to PASA and to the Special Interest Group, Jane Simmons and others. And with that, I want to wish you all a very, very good afternoon and a safe, long weekend. From me, bye-bye.
Bye.
Thanks. Bye-bye.
Bye.
Thank you, everybody. Bye-bye.
Everybody, thank you very much. Bye-bye.
Bye-bye.
Thank you so much.
Thanks,
Thanks everyone.
Thanks, bye-bye.
Thanks, cheers, bye.